A patient presents with aggressive swelling of the face and lips. They are struggling to swallow and their airway is narrowing by the minute. You follow standard anaphylaxis protocols and administer adrenaline, but as you rush toward the trauma bay, the patient does not improve. The swelling advances. Adrenaline works for histamine-mediated reactions, but it has no effect on bradykinin. This tutorial will walk through how to manage these specific cases by distinguishing between allergic and non-allergic angioedema. To manage this transition, you need two things: the patient's complete medication history and your facility's specific non-allergic airway management protocols. Identifying this specific mechanism is the only way to move away from an ineffective treatment and successfully secure the patient's airway. Begin with an immediate assessment. As you check the airway, pull the patient's medical history and look specifically for an active ACE inhibitor prescription. You might rule out a medication taken for years without incident. However, ACE inhibitors can cause sudden swelling after years of stable use. In fact, half of all reported cases occur 30 days or more after starting the medication. While this can happen to anyone on the drug, remain vigilant when treating older adults, women, smokers, and patients of Black or African Caribbean ethnicity. A history of long-term tolerance does not rule out the drug as the primary cause of a life-threatening emergency. To determine the underlying mechanism, visually inspect the patient's skin, looking specifically for hives. The presence of hives differentiates the causes. Histamine reactions appear quickly with hives. Bradykinin reactions progress slowly and lack hives entirely. ACE inhibitor-induced angioedema follows the bradykinin pattern, presenting with facial swelling and a complete absence of urticaria. If you suspect this non-allergic mechanism, discontinue the ACE inhibitor immediately and permanently. Ensure the patient knows never to restart it. If treated as a standard allergy and the patient remains on the drug, you leave them at risk for a recurring, potentially fatal event. As soon as you recognize the signs of a non-allergic reaction, immediately switch to your department's bradykinin-specific airway management plan. Do not wait for adrenaline to take effect. If the reaction is bradykinin-mediated, it will not respond to standard anaphylaxis treatments. Prioritize constant airway monitoring and involve specialists early. You may also consider ordering a C4 level test to help confirm a non-allergic cause. Once stable, report the reaction via the MHRA yellow card scheme. Provide exact reaction timing, treatment dates, and any concomitant medications to track delayed cases. Shifting your clinical approach saves the patient in the trauma bay, while reporting the reaction protects others across the healthcare system. By recognizing that an ACE inhibitor can trigger a reaction even after years of use, you identified the bradykinin-mediated mechanism and stopped the drug. The patient is now stable, the medical record is updated, and the adverse reaction has been formally reported. Before your next clinical session, review your facility's specific protocols for managing non-allergic airway swelling. Being familiar with these specific steps today ensures you can take precise action the moment a patient's airway begins to close.